Okay, so we are recording now. So yeah, you are very welcome.
Yes.
Maybe I can introduce you first. So today's ground round is going to be about aortic stenosis and small aortic annulus and its management. And we have the presentation from a team from Chile with Dr. Andrés Diaz and Dr. Juan Contreras. And we have the moderation from Dr. Feindel from Toronto, and the co-moderation from Dr. Alejandro Martinez from the Sudamericana Association of Cardiology. So thank you very much for joining us and for participating and supporting this event. And yeah, we are glad to have you here, and I'm sure we are going to learn a lot. So yeah, please go ahead, and you have the word.
Okay, thanks, Mateo, for inviting us to this meeting. And my name is Andrés Diaz, and Dr. Contreras is going to talk about a review from this tema, and I'm going to show you some clinical cases that we have faced with. The first patient is a 63-year-old female. Sorry, there's a little noise. Okay. She's from Chile, South America. This is the kind of patient we're talking about. She came with symptomatic severe aortic stenosis. We estimated an aortic valve area 0.4 square centimeters square and mean gradient of 87 millimeters of mercury. The annulus was measured in 20 millimeters. She has no coronary artery disease, hypertension. Her body composition, she height 150 centimeters and weight 76 kilograms. Body mass, body surface around 1.8. What are our choices, our options? Well, in the first place, we can perform a mechanical aortic valve replacement or a biological or a tissue valve replacement. In the other hand, we can perform a Ross procedure or TAVI. In our country, Ross is not a feasible option, mainly because of we lack of pulmonary homograft. And TAVI is too expensive in our reality. So we decide to go for the conventional open heart surgery. We perform standard cannulation, antegrade and retrograde cardioplegia, and we watch for a tri-leaflet valve severely calcified. The intraoperative measurement of the annulus was a very small annulus, neither a 21 or 19 trifecta valves fits in the annulus. So Juan decided perform posterior annular enlargement with Nick's technique using bovine pericardium, small stitches, small platelet stitches from outside in the non-coronary sinus. Trifecta valve 19 did not fit, so we decided to perform a mechanical valve replacement with a St. Jude 17 valve. Coming off pump, the patient occurs with refractory ventricular tachycardia. The echo showed no flow in the ostium of coronary artery, so we decided to perform a coronary artery bypass graft to the left anterior descending artery and right coronary artery. After that, patient did well and was discharged from the hospital 10 days later. Case 2. This is a female patient, 70-year-old. You can see both patients are female. This is a problem we usually see in female patients. She also came with symptomatic severe aortic stenosis with a bicuspid aortic valve severely calcified, aortic valve area 0.8, mean gradient 60 millimeters per mercury, non-coronary artery disease. She was quite small, also 152 centimeters, weight 79 kilograms. And we perform, in this case, standard sternotomy, aortic and single venous cannulation, antegrade and retrograde cardioplegia, cool to 34, 35 degrees. This is the standard procedure. And we can see a bicuspid aortic valve severely calcified, small aortic annulus less than 17. And the procedure was the one that you can see in this picture, classical posterior enlargement with Nick's technique. And we can fit a St. Jude 17 prosthesis. The post-operative course was with a transient focal neurological deficit, which was completely recovered and discharged in the 7th post-operative day home. In her follow-up, she denied any symptoms. New York Heart class 1 and the echo shows mean gradient of 16.5 millimeters mercury. And a normal ejection fraction, as you can see in the images. There's a
Andrés,
little noisy. So yes.
Do you want to stop here for any question or commentary from Dr. Feindel? Before to say that, something really common that I found in the south part of my country is there is a relation pretty common. I think there is more report about that, especially with these people from Mexico and South America, and they have the association between a small aortic annulus and low implantation of the coronary arteries. This is why trying to find some more solution in the previous case, probably it was something that I couldn't assess. In the two previous cases, it was a 3 consecutive case. I don't know why, but some people say it's always a bad case came in triplet, and the first patient died in OR because I occluded the coronary arteries and I couldn't came off bypass by refractory. The second one I was prepared, probably I did a path, probably a small that I will proceed in this moment. And the third case that is this lady who is 6 years later is doing well. It's completely asymptomatic, but the valve is really small.
Well, it's a real problem, Juan, especially with the small annulus. I guess going back to the first case, the echo measured 20, and yet you couldn't get even, you had to put a 17 in. I'm just wondering, were you able to look at the echo yourself or measure it? Was the measurement wrong, or do you think they had difficulty with calcium trying to get an accurate measurement? What do you think happened?
I think mainly the measure was inaccurate at the beginning. And because we receive patients from different parts, it's probably the same that you suffer when you receive some patient from Thunder Bay. Yeah. And we consider the echo was good enough, but then in OR we find some surprises sometimes.
Right, right. I mean, very difficult situation. I mean, you had no choice. Sorry, in the first case, there was a NIC. You did do a NICS? I can't remember now.
No. We don't. We did just St. Jude valve.
Okay. We
don't have NICS.
Do you think in retrospect, if you'd put a patch down, cut across the non-coronary annulus, you might have been able to get a 19 in, do you think?
I think probably if I do the same case in the past, probably try to use a bigger patch.
Right, right.
But my problem is still, I don't know, because the problem here is not the annulus, is when I place the valve, the sewing ring occluded the coronary arteries.
Yeah. I think that's a real problem in a small, because the sewing ring diameter, whether it's a 27 valve or a 17 valve, it's still a big, the ring becomes bigger and bigger relative to the valve size as you go down in size. And I find the small St. Jude valve can be very challenging, and the sewing ring starts to push against or get close to the coronaries. I know exactly what you're talking about. When the coronary arteries were very low, it was probably very difficult. Ideally, maybe a stentless valve, but you didn't have access to something like that. Very difficult. But she ultimately did well.
Yeah.
So I think I don't know what else you could have done. I think you could have, I'm sure next time you'll put a bigger patch in and try, and at least that helps the coronary artery, especially the left main, pull away a little bit. You can actually, even as you know, cut underneath between the annulus and the coronary artery and patch underneath that, as long as you do it carefully, because you don't want any bleeding, as you know. And I think that would have helped release the left coronary a little bit. I'm not sure about the right. You may have still had to do a bypass to the RCA, but that still would be perhaps a better solution. And TAVI, even if you had access to TAVI, would not have been an answer with these low coronaries. You would have occluded them for sure.
Yep.
That's
I don't know,
a good point.
Andrés, I think that would be a problem, eh?
Yes.
With the TAVI.
Absolutely.
Yeah.
Yes.
Excuse me. Do you have the final gradient of the first case?
No, we don't have the echo, but the patient, I see
well?
the gradient is doing well, but the gradient is around 20, but we didn't have any recently echo of that. All these cases were performed, I think, in 2018 before I went to Toronto.
Maybe we should remember that this is our country, Chile. So we are living in this place, the pink part, but we receive patients from all this area. So it's difficult for us to follow up because these are very far places. Some live in island with difficult access to medical attention. So it's common to have losses in follow-up, and we frequently lost contact with patients.
Right. Can I ask what distance is between the northern part and southern part of Chile? It looks to me like it's almost like Canada.
Yeah, it's like from the Nova Scotia to Vancouver.
4,000 kilometers.
Wow.
From here to here. And our geographic area is 600 kilometers. All this area.
Wow.
Should be around 600 kilometers. It's very narrow.
So Canada, that's almost that would be like almost 3/4 of the Canada going east to west. That's amazing.
No, I see it's the same distance going between Nova Scotia to Vancouver.
That's amazing. Wow. It's hard to appreciate till when you see it on a map like that outlined. It's amazing. So it must be very difficult for follow-up.
Yeah.
Wow. Yes, that's true. The videos have sound. So I will continue with the last case. The first two cases were operated by Juan, and this case is the one I performed around 10 years ago. I was a young surgeon. I did things I probably won't do it again, but I think I have to learn from my mistakes, and I'm going to present to see what you think about. Well, this case is a 33-year-old female. Now is 33. When I first saw her, she was 23-year-old. She has story of congenital aortic stenosis. She has gone prior aortic valve repair and subaortic resection the year of 1995, when she was 7-year-old in another hospital, another institution in Santiago, a pediatric institution. Then she came to us in the year 2012, and we performed an aortic valve replacement with an ATS mechanical prosthesis number 16 and resection of remnants of subaortic membrane. In that case, in that moment, the annulus, the aortic annulus, was measured around 17 millimeters. Sorry, 16 millimeters.
How big a lady was she?
That's important. She is quite larger than the first cases. She is around 1.7 meters and 75 kilograms. She's much bigger than the first cases, and the annulus was really small. She's a young woman, so I give her a mechanical prosthesis, so it's complicated, but it was the best chance I had in that moment. This is the CT scan from that moment, year 2012. Okay, I just want to show you. She had a really quite normal aortic root and aortic and ascending aorta. Sorry, it's a little difficult to control the scrolling, but here you can see the aortic annulus. The radiologist measured around 15, 16 millimeters, and the aortic root and the aortic ascending aorta was quite normal. Just give me one last chance to try to control the scroll. Yeah, here. One thing I want to show you is here. You can see the left LVOT seems narrow. In that moment, I didn't give that much attention. So her current status is she has mild symptoms, but she was thinking about getting pregnant. So in control, we do a new echo where you can see normal ejection fraction, non-dilated LV. The aortic valve seems to move, both disc moves quite good, but in this long axis for 3, let me see. We can also see both disc moves nice, but the LVOT seems to be quite narrow, and the anterior mitral leaflet almost touch the septum.
So there's some potentially SAM.
Potentially SAM, yeah. And you can see high speed jet from the subvalvular area to transvalvular. Here are the measure of the aortic root, which is normal, 3 centimeters, and the annulus, 1.7 centimeter. And here's the problem. Subvalvular measure is around 17. Sorry, this was not, the number was erased, but it was around 12 millimeters in the maximum subvalvular diameter. And the problem is she has at rest a mean gradient of 87.4 millimeters of mercury. Remember, she's very young, 33 years old, mildly symptomatic, but she wants to get pregnant. So what should we do? This is a case we haven't solved yet, but with the return of Juan, we have some ideas, but I'm happy to hear what's the opinion of the expert. So here, finish my part, and I give the word to Juan to continue the presentation.
Yeah, well, in the last case, in summary, is a 33 years old lady, 33. She has normal aortic root. The annulus is around 17, but the LVOT is 12. I don't know if someone from the attendant they have. I think I saw Dr. Heredia from Mexico.
How thick is the septum?
Yeah, how thick is the septum?
12.
Yeah. 12.
The septum is 12.
12.
12.
Yes. It's not hypertrophic. It's quite normal.
Have you give her medications like beta blockers or something?
He's on beta blockers.
It's on beta blockers, yeah. and still it's 85 the gradient.
Yeah.
Yes.
And she has mitral regurgitation now?
No. Normal mitral valve, normal function.
Right. Well, I don't know about getting pregnant.
Well, she get pregnant last year, but she made an abortion. Yeah, but
how far did she get? I mean, was it early abortion?
Yes, 12 weeks.
Yeah. Oh, okay. So she hadn't built up the cardiac output. And...
Is she having some mitral valve? Some?
Not in this moment. No, she has all the settings to make some, but it's not a problem in this moment.
Yeah, I think my theory for this case is considering different options. She has a severe gradient, and even when she's not symptomatic, we should offer something. The problem if the root is normal, even if we do for example, the most common posterior root enlargement, we cannot resolve the problem. And the other option we can consider for this patient is to do an anterior root, an anterior annulus enlargement, that means a Canarasa procedure. But the problem is not many surgeons we are familiar with this procedure. And the other problem is we know that most of these patients develop some ventricular dysfunction secondary to the resection of the incision in the septum.
Yeah, I agree. I think I have minimal experience with a cono. I've only seen one when I was at the hospital for sick children in Toronto. young children seem to tolerate incisions in the RV and the septum better than adults. Adults have a lot of trouble with the RV, I think. Juan, do you think that 13 millimeters was the septum?
Yeah.
Yeah.
Yes.
So I mean, you could you'd end up doing a very limited resection with very caution. But if you even reduce the gradient of the aortic valve, you'd have to take out that valve.
Yeah.
And if the gradient goes down, you may end up back where you started, I guess. I guess there's some advantage now having a smaller valve, and at least is somewhat protective.
Yeah.
But the way she is, if I would be very worried that if she gets pregnant, she could end up having a catastrophe. I think. That's a very difficult case. Do you think you could safely take out a little bit of septum? I just don't know how much that's going to change it. It's not. With that. Pardon?
Because if we consider even cutting some muscle, doing a small myectomy, and if even we consider replace the root, doing a ventral, trying to give more area, still the problem is there, because I think the valve in this patient is working properly, but the main problem is the acceleration is below the valve.
Ese ejercicio está ahí. Vaya, cámbiese.
I found it. Yeah, I don't know if someone from the attendant, they have any question or they have any suggestion about that. No? Dr. Martinez?
See, I think one alternative, if you have some mitral valve apposition to the septum, is to do a mitral clip.
But she doesn't have SAM now.
No, now.
No, but
No.
Yeah.
No, because I think there is no a SAM. Probably there is some acceleration, but the problem here is the LVOT. The left ventricular outflow tract is small.
Has she been, she gets symptomatic with stress, or have you provoked her, like tried to, it's a bit dangerous, but.
I seen this patient, when I talked with her, she denies symptoms, but she has some.
Yeah.
I think she's trying to tell us that she's fine.
Yes, she has also anxiety disease. So sometimes she is more symptomatic. Other times she's very well. So it's not easy to really quantify her symptoms.
I just don't know how much muscle you could take out safely, Juan, and help her without risk. You know, you don't have much septum to work with.
Yes.
And I don't know. I don't have enough. I don't have experience with conos in adults. I would be quite concerned. I'd be curious to see what my colleague, Dr. Ralph Edwards, thinks.
Well, maybe we can send the photos later.
Yeah, I was with him this afternoon in the operating room. I think he would, I'm not sure what additional information he would have, but he's our expert, one of the Canadian experts in hypertrophic cardiomyopathy. This is a very challenging case. I can understand why she's anxious. What are the, has she been advised not to get pregnant, at least until we get some answers?
Yes, that's for clear, for sure.
Yeah.
I had, last year, I had an idea when Juan was in Toronto. I had the idea to make a MRI and I don't know, and get a 3D printing of the heart, and then I look for the best approach to enhance the LVOT. I don't know if 3D printing can help us.
It's interesting. So you could at least see what the best approach would be. Are you very confident with the septal measurements? That, I mean, it's hard to tell here, but
yes.
I went when they are doing the echocardiogram, and it's a completely reliable and
yes,
echocardiogram.
Absolutely. She has several echocardiograms, so
okay.
I have been follow her. She has not lost follow-up. I have been follow her for years, and we are very sure, pretty sure.
But she does not have the rest of her heart is not hypertrophic or anything. It's a normal heart.
Yeah.
Boy. Yeah, I'd like to see what Ralph Edwards thinks. I just don't know how, you know.
Yeah,
I think every surgeon is nervous about, you know, creating a
here
VSD.
you can you can have an idea of the septum in this fourth chamber.
Yeah, nothing to cut out there.
No.
I mean, medical management's the other option, but I don't think she can get pregnant. That's very tough for her. But if the alternative is dying in a pregnancy, that's pretty horrible.
Yeah.
And you know, as you said, Juan, you know, you can do anything. You put a root in or like a freestyle or whatever. It's not going to deal with the subaortic obstruction.
Problem. Agree.
It may be something she has to accept. I don't know, but I'd like to see what Tony Ralph Edwards thinks. But I agree with you. Looking at that echo, I wouldn't want to be sticking a knife down in there. You have a real problem.
Yeah. Then
I think we should continue.
Yeah, we want to do a small revision because in theory there is a resident from different part of South America, and we did a small revision about a small aortic annulus. 1% short of time. Can you stop sharing, Andrés?
Okay.
Or if you want, yeah. Okay. Yeah. Can you see the slides?
Yes.
Yes.
Nice.
As you know, this is the normal aortic root anatomy. But when we talk about normal aortic annulus, we have to consider that the normal annulus is smaller than we saw. This is a review from the different homographs that were taken in the state. And they found the measure of the normal annulus in male is 23 and in female is around 21. What is the problem with the small aortic annulus? Well, there are several surgical strategies, and most of them are challenging, but the most important thing at the moment to approach this patient is the surgical experience. What is the significance of the small aortic annulus? Well, we know the patient has more difficult surgery, more bleeding, more annulus injury, more heart block, and they increase the risk of prosthesis mismatch associated, and they have poor outcome after AVR, and they increase the mortality, ischemic event, and stroke. What is the definition of the small aortic annulus? Well, that can be measured by preoperative or intraoperative. And we consider that the annulus low is smaller than 23. And at the moment of trying to place a valvula, the valve, if we cannot place a prosthesis less than 21. What is the prevalence? Well, we know that there is the prevalence of that is around 22 to 44 in the state. That is more common in Asian population, and I seen is more common in Latin American person. There is no proper evidence from Latin America, but for sure, at least in my center, is really high. I think we place probably 30% of our case prosthesis less than 21. Wow. And it's more common in women. We know that how they consider the prosthesis mismatch. Well, We consider severe if the size of the annulus with the body surface is less than 0.65. And if we go to see the valve, every patient who has a body surface area more than 1.3, less than 1.3, and with valve less than 90 we are going to get some prosthesis mismatch. What is the impact of the prosthesis mismatch? Well, we know that severe almost duplicate the risk of mortality, and in moderate is 1.2 higher than the normal. This is a review from the group from Brazil, and they found obviously the prosthesis mismatch increased the perioperative mortality to 1 year, 5 years, and 10 years. How we have to measure the annulus? Well, the proper way is do it by echocardiogram before the surgery, but the gold standard in this moment is the CT, because they can give all the measures that we need: the annulus, the relation with the coronary arteries, and it's a really good strategy. What is the problem with for the surgeon? The first problem is there is a no standardized system to compare the different valves. And here, this is a slide from Dr. Juan, who presented that is in CTSNet. And they see, for example, if we try to say, oh, this patient has a size 25, at the end, we're placing a valve 21. And if we compare, for example, in a patient who has placed a Magna Easy valve 19, the final inner diameter is around 40 millimeters. That means really small. How we have to approach the small aortic annulus? Well, we have the echocardiogram, the CT, we have the surgical measure, and the thing we have to think is about the patient, and we have to try to offer the best valve possible for the patient. How we can avoid the prosthesis mismatch? Well, first we have to choose the best valve for the patient, and we have to consider the predicts affected orifice of the aortic valve. We have to consider the different model and size, the body surface area of the patient, and we have to consider the preoperative echo, and then we have to compare with the surgical measure, and then we have to see how we can place our valve and try to offer the best affected area for the patient. This is all the prostheses that are available in the market, but if we compare the surgical valve, in this paper, Carpentier, Magna, Trifecta, and obviously St. Jude and Onyx, they offer the best affected orifice area. And if we add to the new valve for Avalus Perigon, they offer the better affected orifice valve for this patient. If we consider the stented prosthesis, well, we know that at this moment, more than 80% of the aortic valve replacement are performed with bioprosthesis valve. And even with that, the presence of the prosthesis mismatch in a small annulus is really high. Some people consider that consider all the different type of prosthesis mismatch go between 45 to 90%. If we just consider severe, go between 4 to 20.5%. We know that the supraannular implantation of the valve offers the better profile and better outcome for this patient. And we know that place a valve 19 and 20 or 21, they increase the risk of deterioration of the valve and increase the rate of reoperation. About the same valve, there is a alert last year that was presented from the American Society and the European Society with some early deterioration in trifecta prosthesis. This is why, for example, center like Toronto, we didn't use that valve. This is compare between probably the two best valve available in the market at this moment. Probably is Magna East versus Avalus. And the interesting thing is both of them, they have really good profile. And in this Japanese series, they found that Avalus valve, they have less severe prosthesis mismatch compared with Magna. That is pretty interesting. And if we see in the market, probably the best valve available in this moment, there is a Perimount, Magna Easy, Avalus, and Trifecta. If we see the Stellet valve, well, they offer, they have better profile. And one of the potential use of this valve is in this setting of patient, to place a freestyle valve in patient with a valve annulus less than 20. But we know the problem with that, the people say that calcification in the long term is really bad. And if you have to reparate this patient, it's really complicated. Another option is a sutureless valve. They offer a easy implantation. They offer a less cross clamp and cardiopulmonary bypass. And in theory, they have a better profile compared with the stented valve. TAVI is another alternative, and is considered a patient with who has intermediate or high risk for severe aortic stenosis. Some people say now in patients less than 75, we have to consider. And in theory, they may offer a better profile in the long term, but we don't know. Just consider for the technical valve consideration. Well, the first thing is if you have a small annulus, you cannot consider the standard implantation of the valve with a platelet from the aortic valve, because you place the valve in an annular position and you decrease the final affected orifice area. Some consideration for that, we consider either small platelets, supraannular implantation with the platelet in the ventricular phase, not use platelets, and just consider 8 shapes, consider running suture, core knot, and the other option is use a platelet from the outside to inside in the non-coronary sinus. Regarding the annulus enlargement, well, that depends. I think sometimes in South America it's difficult to find center that they offer like a route enlargement. This is something that I learned a little different in Toronto, because they're more aggressive, try to enlarge the aortic root. And I'm going to tell maybe the 3 more common procedure. Maybe everybody's more familiar with my Manugian technique and Nick's technique. I don't want to extend in this procedure. I want to show this aortic root enlargement that I think at this moment is my favorite. And it's not because Dr. Feindel is here, because it's really simple to do it. This is the aortic root enlargement that was described for Dr. Feindel. And the thing that he performed is resect the all non-coronary sinus, and then he placed a patch. And the interesting thing is everybody, when we try to sew the patch, everybody tried to continue in the initial aortotomy, but Dr. Feindel extend this part to superior toward the aortic cannulation, and they offer a really symmetrical repair at the end. This is the video that was. This is the video that he was published in CTSNet, when you can see the detail of the valve, the root enlargement. Some significant trick here is one is try to resect the valve with a knife, try to resect all the calcification and avoid any residual calcium in the annulus. Then Dr. Feindel resect all the non-coronary sinus, as you can see here. And this is the final. This is the finally how you can see the resection. Then he cut the path like a drop, and he saw the suture with a, I see this Prolin 4O, and then he add a second layer to avoid any leaking. Then he placed in the left coronary sinus and the right coronary sinus, he placed in the normal way. But then he add the stitches for the non-coronary sinus from outside to inside, and he reinforced with a band of the vine pericardium. Dr. Feindel, I'm missing something from here?
No, the only thing is, if you, this particular video, we didn't actually cut across the aortic annulus, but you could do that, because then you could get even, especially for a small annulus, you may have to do that. So this way allows the valve to be inserted above the annulus, which usually gives you one more size. But if you cut across into the mitral valve, you could probably get even a bigger size. And one of the dangers of that is you can't have the valve down too low, because you will pull up on the anterior leaflet and you'll distort the anterior leaflet and get much regurgitation. But this allows you to place the valve in the non-coronary sinus, maybe half a centimeter above the original annulus, allowing you to, helps you accommodate the sewing ring. So the sewing ring is less obstructive, I think.
Well,
And that's a Hancock valve, which is a much bigger, bulkier valve than the Magna Eves or Paramount. But I think Juan was correct. It's a reproducible operation. Juan, I think just before he left, did a beautiful job. So it's definitely a good technique to use. I think I was probably using it in Juan. I don't know. I think probably 75% of my cases.
Yes, I think so. And I think one important part is usually when most of the surgeons will place a patch here, I think the most common mistake is try to use in that direction. But this part that you are going to do here is really critical, because if you extend the incision toward the aortic cannula, I think the final result is much better. And you can see the final, you can see here the final result. Looks pretty nice. You can see here.
Sí.
I think someone has the mic on. And this is the final result. You can see it's really symmetrical, the valve.
I've seen, sorry. Go ahead.
No worries, Dr. Feindel.
No, I think, as Juan said, if the patch is not extended up the aorta, you can get quite a bit of distortion of the patch. And I've actually seen a case in the United States where the patch was cut in a way and sewn in a way that it occluded about 60% of the ascending aorta just above the valve. It was quite amazing.
Yeah. I think if you don't do this incision toward the aortic valve, you finally has kind of like a sunglass with a supravalvular stenosis.
Yes.
Then the other option that we will consider for our patient is do a Canarasa procedure. The most,
Oiga, la mamá de Carla de primero.
you know, I think someone has the mic on. Yeah.
Esto es que sí le expliqué hace un momento mi.
Yeah, okay. Okay, another option is that we are considered for our last case is a Canarasa procedure. This is more effective for aortic root enlargement. It's more common in pediatric and an adult congenital patient. This is really surgeon dependent, and I think most of the adult surgeons, we don't have many experience on that. And the most difficult part, or the two potential issues with that, is the residual VSD and ventricular dysfunction secondary to damage the septal perforating artery or conal branches.
It's unclear to me why there's so much trouble in the adult and the right ventricle. Possibly, the right ventricle is more hypertrophic, when a young child, but they seem to tolerate this procedure much more. But adults, this can be lethal.
Yeah, and this is the surgical description when you can see you open the aorta and then you do an extension in the RV. And then you have to place two patches, one to enlarge the LVOT and close the aorta, and the second one to close the the RVOT. This is the final effect. You can see this is the initial area, and you can see because adding 2 patches, you increase, you extend the valve toward the RVOT, and then you have to add a second one. This is a really interesting video from Clinica Mayo, and when they do the description, they are resecting the valve. This is the, and then they're doing the extension toward the LVT, and this is the RVOT. Then he resects some muscle. And with that, they increase the area. Then he plays some pledges, trying to give more area for support the patch for the LVOT. Here you can see, this is the LVOT enlargement, then they place the valve. You're placing an appendix. And then when you close the aorta and you have enlargement of the LVOT, you have to add the second patch for the RVOT. And this is the final result. In theory, the benefit of the anterior root enlargement is that you can increase at least 2 or 3 sizes the valve. This is the theoretical. Well, we talk about root enlargement. Obviously, it's a surgical dependent in terms of the expertise of the surgeon, but there is a several review or meta-analysis that they try to find if the surgical enlargement of the aortic root increase the risk of the operative mortality and long-term outcomes. And in different report from Toronto, there is no increase in the mortality, acute myocardial infarction, in the permanent pacemaker, infection, stroke, preoperative bleeding, and renal failure. This is showing the same, but now in several Canadian institutions. And this is there is another meta-analysis by the Brazilian team that showed the root enlargement doesn't increase the risk of outcome doesn't decrease the outcome in this patient. What are other potential options for this patient? I think this is a really interesting technique. This is the novel simple technique by the Dr. Bu Yang. He did the incision between the non-coronary signon and left, and he proceeded kind of a Y incision, and then he placed a square patch. The benefit of this technique is in theory that he increased 4 sizes the valve. Sound pretty amazing, but I don't know how reliable and how easy to reproduce is going to be that. Another option
I'd be concerned about the mitral valve. Whether you'd be distorting that, that would be my concern. It looks like an interesting technique, but it looks like based on the incision that, you know, if you have the patch right, it should not distort the mitral valve. As long as the mitral valve, you know, where inserts on the aortic annulus, or that it's not pulled up with a patch, I think that would be the concern. So you must be very careful with that.
Yeah, and I think probably for fragile patient, this is not a good option.
Right.
Another option is a complete aortic root enlargement. You can see here when you have the problem, just enlarging all the valve, you can increase the size. Other really good option is the Ross procedure, but I've seen in South America, there is just few countries or just few places in South America you can use the Ross procedure because the homograph is no option to everybody. And they offer a really really good outcome in the long term. Another option is considered that procedure is for reconstruction of the intervalvular fibrous annulus or UFO. But the problem with this technique is that the perioperative mortality really in really good hands is around 10%. Other option is the Osaki procedure with adding some root enlargement, but as well as a complex patient. And to finalize, in case if you have or you suspect you have a small aortic annulus, first you have tried to choose the best valve for your patient. If you have like a low risk of prosthesis mismatch, you can proceed just with your aortic valve replacement. Some people said if you have to offer less than 23, you should consider a newer generation valve, consider TAVI, consider aortic root enlargement, or if the patient is really fragile, well, you have to consider the patient is going to get his prosthesis mismatch and he has to tolerate as much as possible.
I think, Juan, I think it's important to remember that even though this patient prosthesis mismatch, it's hopefully a lot better than when the patient had severe aortic stenosis.
This is a really good point. As conclusion, well, the management of a small aortic annulus still is a controversial and it's a depend of the surgical expertise. The prosthesis mismatch increase the mortality. The aortic root enlargement does not increase the operative risk, and I think we should consider to use more common. And I think currently in the market, the best tissue valve in this moment, there is a Magna Ease, Anulus, and other options on stainless, consider the Ross procedure, and the TAV is a valid option in patients with moderate and high risk. And this is the presentation. Now, because we have the Dr. Alejandro Martinez, who is an interventional cardiologist, I would like to know, Dr. Martinez, if you can talk a little bit about small annulus and TAVI. What is your experience and when do you consider to use TAVI in this patient? Dr. Martinez?
He might be mute. I don't know if he's hearing right now.
Yeah.
Juan, can you open his microphone?
I try. Maybe he's not here. Dr. Martinez?
Juan, can I ask you a question while we wait for in the slide number 58?
Yep.
Yeah. You say that we should determine expected index effective aortic area.
Yeah.
Where can we get that number? Because you said that the numbers that the industry give us are not the real numbers.
Yeah, but I think first you have to consider your echocardiography before your surgery, the annulus, where the body surface area, and then there is here, this one.
This is from the Quebec group, I think.
Yeah.
Dumanil.
Yeah.
Okay.
This is I think this is the table that we should have in the door of our OR.
Okay.
But I think the this problem of different companies having different measurements for the same size valve has been around, well, ever since I was a resident, I remember, and it's a real problem. So you end up, you know, a Magna Ease 23 millimeter is not the same as a Hancock 23 millimeter. In fact, and I think, Juan, we did this in the OR, if you put a Magna Ease 23 and hold it up against a Hancock 25, the internal diameter almost is exactly the same. So it makes the Magna Ease look a lot better. So if you put a Magna Ease 23 against a Hancock 23, the Hancock it has a worse, a smaller annulus, but they're still listed as 23, and it's very confusing. But I think that's why in the smaller valves, we like to use the Magna Ease or the Paramount, because I think it's just the way the valve's designed. But it's a very confusing issue. One of our surgeons in Toronto, George Christakis, wrote an article really criticizing the industry many, many years ago, and nothing changed. Because I think they use different, they measure different things and then put these numbers on the valve. It's very confusing.
Mateo, are you there? I think he's not there as well. Well, maybe Dr. Feindel, you can tell to everybody how's the strategy for bioprothesis in Toronto. What kind of prosthesis do you use?
It's mute.
Okay, now, is
Yeah.
that good? Good. Sorry, you had to make us all go quiet, Juan, or somebody.
Yeah, I think it was.
Sorry, what was the question, Juan?
If you can explain how's the strategy in Toronto, when you use what kind of valve, when you go for what kind of prosthesis are you using? Maybe when you use Cornot with a different kind of valve, when you use Anulus, Magna Ease, or when you use a Hancock. Oh, that is not me.
Okay, now something happened again. Can you hear me? Yes. Okay. You can hear me all right?
Yeah.
Yeah. Okay. Well, for years we've used the Hancock valve for many, many years. It has we've had excellent outcomes with it. Very hard to match with other valves. However, we used it a lot longer than the Paramount or the pericardial valve. So the Hancock valve in a large size is, I think, very effective. It has excellent durability. My own theory is because it's a PEG valve, it's more natural, and because it's a higher profile, there's less stress on each leaflet. So I'm in theory, then you'd think it would last longer. So for a male, I usually like to put in a 25 Hancock or higher, or in a female, a 23 or higher. If it's going to be less than that, then I would switch to a Paramount or now the Magna Ease, which is essentially the same type of valve. Again, well, for some of the cases you presented today, those are huge. Those are very big numbers. For a smaller woman, I think we really like to see a 21 valve, a tissue valve if we can, and a smaller man, a 23. And the smaller sizes, I would use the Paramount or the Magna Ease. And of course, there's a mechanical valve if it's a younger person. As you know, I think there's less and less mechanical valves being used as we get older. People, I think, feel that the use of TAVI to repair a biological valve is an option. However, the concern about that is if people put in relatively small biological valves, putting a TAVI inside that is going to likely create stenosis. I'd be interested in the comments from Alejandro about that. So I think as a surgeon, it's important to get as good a big size valve as possible, even if you're going to repair a biological valve in the future with a TAVI. I think that's an important concept and helps justify even doing a root enlargement. And as Juan said, initially when root enlargements were done, even from our own center, the mortality was higher. And there was quite a bit of criticism. So there was a reaction, especially in the States. Everyone said you can put in small valves, no problem. I think small valves in people that are big or larger is a problem. I think a small valve in some of the cases you presented today, small people, it's acceptable because you don't have much choice. The other option, of course, is a complete root replacement with a freestyle valve. They have excellent gradients, as you know. However, as Juan mentioned, if you have to do a repeat operation in someone with a freestyle that's been in, for 10 or 15 years, it can be very challenging because of all the calcium that develops in the aortic valve and the annulus. So I think that's kind of our approach. So larger annulus, we've tended to use the Hancock simply because we've got excellent long-term results, which haven't really been matched by any other valve, although there's been no randomized trial. So that's just an observation. And smaller annuluses, we go to a pericardial valve with a root enlargement for the tissue valves. Yes.
Oh, sorry. I wanted to ask you something. I mean, you have been talking about this the whole time, and Juan and Andrés as well, but there is like I have heard sometime a sentence, I don't know who is the original author of that sentence, but he was saying that bigger valves kill more people than small valves. Yeah. I mean, you are an expert, and a lot of people have experience and can do different procedures to increase the size of the annulus and the root and implant bigger sizes, bigger valves. But there are some centers where the volume is not as big and surgeons do not have that experience. So if you do not have that experience enlarging the annulus, enlarging the aortic root, do you agree with that sentence, or do you think it is always wise to try to put the biggest possible valve?
Okay, something I got. Yeah. No. Okay.
Yeah. Now we can hear you again.
Okay, good. No, I think what you're saying is if you do root enlargements just to put a 27 valve in someone who's perfectly okay with a 25 and you don't do it very often, you can definitely get into trouble. One of my earliest root enlargements, and Juan knows this, and he talked about the second suture line when you do the procedure, is if you get bleeding on the lower part of the patch where you're sewing to the anterior leaflet of the mitral valve, you won't know if there's a leak there, you won't know until you come off pump. And then you end up having to fix it. You usually have to go back on, redo the whole operation, or at least take out the valve. And that will lead for sure to a higher mortality just because you've now doubled the pump run, all the usual problems. So I agree. I think one has to be rational. Having said that, I use a root enlargement or a non-coronary sinus replacement quite frequently. And I think the more you use it, the more comfortable you are. And it's not just for that. It's, often how many times you take out a valve and all of a sudden, the next thing you're looking right through the other side of the aorta, and you've got big piece of calcium, and now you've got a big hole to fix. If you use the patch more regularly, you're usually much more comfortable fixing that. But I totally agree. If you do a root enlargement once a year, it's going to be challenging, and I think the advantage is it's just like anything. The more you do it, the better you are at it, and safer. But it's an interesting. I think you're saying you mean a large valve with a root enlargement is killing people. I think that's what you're saying, was it?
Yeah, basically. I mean, if you don't have a big experience, it can lead you to trouble.
That's true with anything. Okay. I have no experience flying an airplane. I would have a lot of trouble.
How's the experience in Leipzig, Mateo?
Yeah.
How do you approach a small annulus?
We do hear a lot of enlargement actually. We use the NICS technique very often. Also, I mean, we try to use the biggest possible valve actually. like, let's say it's almost a fail if we don't get a big valve inside. Only in very bad cases, when it is really, really small and like impossible to enlarge, then the patient is gonna get a small one, but usually we do a enlargement here actually.
But how small is a small in German? Maybe 25.
Well, yeah, the German population is big. So yeah, I mean,
Yeah.
the standard valve here is 25, 27, less than 25 is small.
Even for women.
Well, women actually 23 will be
Yeah.
all right. But you have sometimes people even smaller than 23, and then you start thinking about what to do. But I don't know if it really makes a difference if, as you mentioned just before, if the patient has enough place to implant a 25, if you really have to try to put a 27 inside, because it's just some more additional steps in the surgery that can make things difficult.
Yes, I would agree with that. The problem with the cases you presented today is that if you don't have much experience with a root enlargement and then you're suddenly faced with a 17 millimeter annulus, and that even, I mean, a 17 millimeter annulus is a challenge for any surgeon. You know, you're worried about all sorts of things you don't have to worry about with someone with a 25 or 27 annulus.
Yeah, and another possible scenario is when you have a double valve replacement, then you first put the mitral valve and then you have no more place for the aortic valves, and you have to figure out how to do it. Yeah,
we always teach the residents, and Juan knows this, that, you know, if you have a big mitral annulus, always undersize it a little bit. There's no point in putting a 33 millimeter valve when a 29 or 31 will be fine, because you'll start obstructing the outflow.
Mm-hmm. Juan, Andrés is writing, asking to be on mute.
I have one question for Dr. Feindel.
Yes.
Well, it happens that we had a fourth case. I decided not to present it in considering the time, but it was about a complication. It presented to me. I performed a root enlargement, posterior annular enlargement with a Nix technique. That part of the surgery go perfectly well. The gradients were low, aortic valve prosthesis function perfect, but in the post-op echo appears a mitral valve regurgitation that was not present in the pre-op echo. The image show a lack of coaptation of the leaflet, about 2 millimeters, and a central jet. Two questions: why could that happen? And the second, how can I avoid it?
Well, I think I had one of those early in my career. It was very distressing, and I think what I had done is the valve was down a bit too low. I was not generous with the patch below the valve. So I think what happened is the valve pulled up on the annulus, and I suspect intraoperatively, you know, things are still, it was working, but over time with a little bit of remodeling, I have to assume it was some remodeling in that area. And then it pulls the anterior leaflet apart a bit. So you get some malcoaptation. In that case, I noted it intraoperatively, but it wasn't severe, and we accepted it, and the patient did all right, but was stuck with some residual mild, moderate mitral regurgitation, which I thought was probably be better than going back and doing, probably end up a new patch or a double valve. You probably end up doing a big double valve, which is a big deal. Is the patient okay now?
Yes, it's okay.
Yeah, I'd leave it.
So yeah.
But I think that's the concern. I think I had that complication very early on, and I guess it burned a hole in my brain, and I never forgot it. So I probably go the other way and make the patch, make sure there's a lot of patch below the sewing ring. But it's a challenge, and I think these aspects of root enlargement, early on, I think these are problems. That's why people, early on had a higher morbidity for sure.
Thanks.
Okay, I think there are no questions anymore. So I think we could finish, right?
Well, you need to get to bed. I guess no chance. No chance.
I'm actually at work, so
I know. So you will be up all night.
yeah, exactly. Okay, yeah, thank you very much. Very interesting. I definitely learned a lot. And Juan and Andres, thank you for preparing the presentation and the cases. Everything very fine, very interesting. Dr. Feindel, we feel honored to have you here and to hear your experience and your commentaries. And yeah, I hope we see us the next time soon.
Okay, that's great.
Yeah.
And Juan, I'm going to ask, can you either send me information about that case or send
Yes,
Tony, or
I will do it.
I'll make sure that he sees it. We talk about it. That's
Yeah,
a very difficult case.
I will share you the complete echo
Okay,
of that patient. Okay.
great.
Okay, bye-bye.
Thank you very
Okay,
much.
well,
It was
thank
a
you
great
very much.
meeting.
It's great to see
Bye-bye.
everybody.
Yeah.
Bye-bye.
Bye-bye.